to learn about lung function test. So I hope in your class also you have done little bit of about that, right? Mechanics of breathing. Have you done? So what are the things you have covered in mechanics of breathing? You have learned about the lung volumes and capacities, right? Then compliance. Then what else? The flow volume curve. Have you seen the diagrams? Okay, then how to interpret. And then your restrictive and obstructive lung diseases. Have you done that? Yes or no? Yes. Okay, so it will be kind of revision class. Okay. So what is lung function test? So another name is also called pulmonary function test. So both are same. Okay. So these are non-invasive tests. Okay. These are a group of tests. Okay. So which is they can measure how well the lungs take in and release air and how efficiently they transfer oxygen into blood. So this is basically see the lung functions, how well our lung is functioning. Okay. So these are group of tests. Okay. So they assess the lung function and identify abnormalities but do not provide any clinical diagnosis. So in this they will not tell you what is the exact cause. So they will just tell you the idea. So is this because of your lung cause or either because of it might be because of lung or by cardiac cause. Okay. So by this you can come to know so the pathology is in the lungs or not. Okay. Then they help to differentiate between the cardiac and pulmonary diseases. They distinguish between the obstructive and restrictive lung diseases. So I will show you the graphs, okay, later on. Then they compare the patient lung function to normal values and previous measurement. So these tests are basically like they will be telling you how much. Yes. So they will be telling you basically like how much is the normal values and we will be comparing the normal values. Okay, after taking the test, we will be comparing is it less. Okay, so if it's less, then there might be some pathology. Okay. So what is the role in clinical practice? So they confirm clinical diagnosis of pulmonary diseases, then they monitor disease progress and treatment response, then objectively assess disease severity, like in case of your pulmonary diseases like restrictive or obstructive diseases. So they can tell you the severity of diseases also. There will be some gradings. Okay. Then in case of before surgery also to check the status or how well your lung is functioning. So to before that also before surgery or before anesthesia they have to check. Okay. Then assess the fitness. So if you are going for any job or military persons, so to check their fitness also, okay, we will be doing the pulmonary function test. Okay. Then also your medical legal information. Okay. So these are the various roles in clinical practice of your lung function test or pulmonary function test. Okay. Okay. So this is the brief classification, how we can classify the pulmonary function test. So based on ventilatory function, then gas exchange test, then cardiopulmonary interaction. So in ventilation, so we'll be learning about the static lung volumes and dynamic lung volumes and capacities. Okay. So what do you mean by static and what do you mean by dynamic? What is static? Static. So what are the, can you name one example of static lung volume? We have so many, right? So many lung volumes and capacities. Okay. Then any capacities? Okay. Okay. So what are the about dynamic? Dynamic. Can you name any? No. Tidal volume is not static. You have to first know what is the difference between static and dynamic. Static means there is no time consideration. So it is expressed in only milliliters or liters. Yes. Why you are so late? So they can be either expressed in milliliters or liters. And dynamics means that is consideration of time. So it can be expressed milliliter per second or in second. So you can name FEB1, force expiratory volume 1, FEB2, FEB3, MBB. Those are your dynamic lung volumes. Okay. Then gas exchange test by the diffusion capacity test. Okay. What is ABG? That is arterial blood gas analysis. Okay. So actually, if I have to describe all of this, it is going to a lot of time. Okay. So we'll be learning more of this. Okay. Static and dynamic. Okay. Then little bit of ABG. Okay. If you are interested, this is another very vast topics. Okay. Then diffusion capacity. So we'll be just having 1 or 2 slides about that. Okay. So you already know. So these are the static lung volumes and capacities. So we have tidal volume. Then IRV. What is IRV? Inspiratory. Yes. I told you before also, you should not click. Everything is there in the book. Okay. You can note down the points. And ERV is expiratory reserve volume. Then RV is reserve residual volume. Okay. Then VC is, what is VC? Vital capacity. Then IC is inspiratory capacity. Then FRC, functional residual capacity. Then TLC is total lung capacity. So you have to know the definitions as well as the normal values. Okay. Okay. So what is tidal volume? So now you are sitting. So now you are in tidal volume, normally breathing in and out. That is your tidal volume. Then IRV is the inspired air. That is with maximal inspiratory effort. Okay. Normally is 3 liter. Okay. So in male and female, the value will be little bit different again. Okay. So these values, it has so many factors which can influence the values. It may be based on gender, age, posture. Okay. Then fitness of the individual also. So these values will be different, little bit different. Okay. According the person to person. Okay. There will be various factors which will be influencing the values. Okay. So these are the normal values. Okay. So vital capacity around. So have you noticed that the capacities are the summation of 2 or more volumes. Okay. So VC is ERV plus tidal volume plus your IRV. So that is around 4,700 ml, or it can go to 4.5 to 5.5 liter. Okay. Then IC is a 3.5 liter. Okay. So these are expressed in ml or liter. Okay. So total lung capacity is the maximum amount of air that our lung can take. Okay. So in outside atmosphere, we have so much of air. We cannot take everything. So our lung has a capacity which it can take. So the maximum is around 6 liters. So beyond that, our lung cannot accommodate. Okay. So this graph all of you know, right? So these are the tidal volume. Okay. So this is basically x-axis and y-axis graph. Okay. So here in the y-axis is the volumes. Okay. So this is the tidal volume. Okay. Then this is, what is this? This one. This is inspiratory capacity. Okay. Then this is your expiratory reserve volume. Okay. So these things are basically recorded in a spirogram. So this is, the procedure is called spirometry. Okay. The process of recording the lung volume and capacities. Then spirometer is the machine. The name of the machine is spirometer. Okay. Then this is the graphical representation, spirograph. Okay. Various lung capacities and volumes. Okay. Then this is the total lung capacity. So what is the importance of this residual volume? Why it is? Yes. So this is basically preventing, or so that our alveoli does not collapse. Okay. So there should be minimal amount of air so that our alveoli can function normally. There should be exchange of gases, right? Then this is the functional residual capacity and vital capacity. What is vital capacity? That is a maximum expiratory effort after taking maximum inspiration. Okay, so that is your vital capacity. Okay, so have you seen any instrument, spirometer? Have you seen any? Not yet. So these are the conditions where your values can be optimum, or there will be the values will be lesser if the person has chest or abdominal pain. So in that case, if the person is performing the procedure, so the volumes will be likely to be lesser, right? If the person has chest or abdominal pain, then oral or facial pain, okay? Then stress incontinence. You know what is stress incontinence? Stress incontinence. So that is when the person is having the paralysis person. So because of they used to pass the urine without their control, they used to pass. So the inspiration, if to do voluntary effort, so that is going to affect stress incontinence. Okay. Then dementia or confusional state. So if the person is not cooperative, so these procedures, if you are instructing the person, so the person has to be cooperative. Okay. So if the person has dementia or confusional state, so he cannot perform, right? So these are the conditions where the values or the test will be affected. Okay. So these are the various indications. Okay. So it might be diagnostic, then monitoring, okay, then your disability or impairment evaluation, okay, then and public health. So in diagnostic, so we'll be evaluating various signs and symptoms, okay, or abnormal laboratory tests. So diagnostic means we are going to diagnose something, okay. Then to measure the effect of disease or pulmonary function, then to screen individuals at risk of having pulmonary disease, then preoperative risk, then to assess the prognosis. So if the person is having any, you have know about asthma patient, right? So if you are giving the treatment to the patient and if you are recording after that, there should be some improvement after that. You will be giving bronchodilators, right? So there should be, you will be seeing the prognosis or how well the person is responding, okay. Then to assess the health status before beginning standard physical activity programs, okay. Then to monitor therapeutic intervention, then the course of disease that is going to affect the lung function, then any injurious agents. So those persons who is working in a, you have heard about occupational diseases. So who is working in a dust industry or asbestos industries. So on those persons, their lung, we are going to monitor, okay, their lung functions. Then to monitor adverse reaction of drugs, okay, to any drugs which is toxic, pulmonary toxicity, okay. Then to assess the patient as a rehabilitation program, then risk of a in insurance evaluation, then in legal reasons, okay. Then in public health, like any kind of surveys, okay, or any research, okay. So these are the indications of your spirometry. So these are the various indications. So you have diagnostic indications, then monitoring, okay, then you have disability or impairment evaluation, then last is for public health in various research or epidemiological surveys, okay. So if you are telling a person if he has to do the pulmonary function test, so these are the things you have to tell him to avoid, like he has to no smoking at least 1 hour before the testing, so that is going to affect the test function, okay. Then there should be no consumption of alcohol before 4 hours of testing. Then you have to tell him not to perform any strenuous or vigorous activity 30 minutes prior to the test. So that there will be, what will happen if he is doing any vigorous activity and doing the pulmonary function test. So that is going to affect the values. There will be ventilation, perfusion, this one will be there, right? Mismatch will be there. Then he has to wear very comfortable clothing, not so tight clothing. So when he is taking or when he is performing the test, so that is not going to restrict the expansion of the chest wall. So he has to come with a comfortable clothing, okay. Then there should be avoidance of taking large meal. So if your stomach is full and if you're performing, that will be difficult, right? So he has to take meal at least 2 hours before the test. Okay. So this is the algorithm, you can say, okay, how, or there is the steps how we are going to follow. So first we will be doing the spirometry, will be flow volume loop, okay, or by the spirogram we will be recording, okay. Then we will find out the stating lung volumes and capacities, okay. Then we will see, does he need any bronchodilators to improve the test performance, okay. Then we will study the diffusing capacity, okay. Diffusing capacity means we will be studying the oxygen, carbon dioxide diffusion. That is a different study is there, okay. Then we will be, after doing all this, then we will repeat again the dynamic studies, okay. So if bronchodilator was given, so it should now improve the performance, okay. Then at last we will be doing the arterial blood gas analysis. So first we will go with the volumes. If nothing found, then we will go to the diffusing capacity, okay. Then bronchodilators also will use, and again repeat the test, okay. Then last will be arterial blood gas analysis, okay, last. So these are the various machines, okay. So these are your digital spirometer, okay. So these are basically computerized. So when you flow air, so it will be recorded in the software, okay. Then it will be given in a print of paper, the report will come when you print out, okay. So this is peak flow meter, this we have in our department, okay. So this is incentive spirometer. So these two we have in our department. This one, have you seen this one? So this is given in a post of patient, post surgery, जिसका surgery हो गया है, to perform. This is incentive. So after the surgery, okay, after the anesthesia, so the patient is to tell, you have to perform the spirometry so that the lung, okay, to improve the lung function, okay. So we have flow sensing spirometers. So what they are going to do, they will be, when you blow the air, when you flow the air, so they are going to sense it, okay, by your computer or a microprocessor, okay. So these are the various types. We have turbine device, then pneumotachograph, okay, hot wire anemometer, then vortex device, ultrasonic sensor. So this is flow sensing. So there will be, the volume is calculated by multiplying flow by time. So I told you before also, spirometer is an instrument, okay, for screening and basic testing of pulmonary function, and spirometry is the recording or the process, okay, recording of various volumes during your breathing, okay. Then, but that is one thing you have to remember this, with this spirometer you cannot measure your residual volume, okay. Then FRC, that is your functional residual capacity, and total lung capacity. For this we have different methods again, okay. So by the spirometer, so you can record majority of the lung volumes and capacities, but except these three. So when you will be getting your practical, so if you are asked which are the volumes you cannot measure, so your answer should be residual volume, FRC, and total lung capacity. You cannot measure by your simple spirometer, okay. So it measures how an individual inhales or exhales volume of air as a function of time, okay. Then primary signal measure of spirometer may be the volume or the flow. So we will be measuring the volume of air or the flow, okay. So it gives an essential diagnostic insight into type and extent of lung function impairment, and can be performed fast, and it is very low cost, okay, and very easy to do, okay. Then, but it requires cooperation. The person has to be cooperative. He has to follow your instruction, okay. Then it will be, the obtained results obtained will be depend on technical as well as personal factors. So personal factors will be your, like your age, gender, then fitness of the individual. Then posture, is he performing in standing posture or in sitting posture? So in the, or lying. So in that conditions also the values will be again different. Okay. So this is Helios spirometer. So this is the practical you will be doing today. Okay. So this is the Helios spirometer. So you have to blow air. This is the mouthpiece. Okay. Then it will be connected to your ear to a computer. So when you blow it, then it will be recorded in a computer. Okay. So this is the test results. You will be obtaining a graph like this. So you have to know how to interpret. Okay. So this will be done in your practical class. Okay. So this is the graph in the Helios spirometer, digital spirometry. Okay. Digital, that is computerized. Okay. So you will be obtaining the flow volume loop. Are you aware of this loop? Flow volume loop. Flow volume loop. Okay. So we will be recording the person age, height, weight. Okay. So after that, it will be already set into the computer, right? Then they will give you the expected one. Then you are going to perform. Then the computer will analyze. Is it the correct? Is it predicted? What they have predicted? Is it coming near to this or lesser? Then they are going to interpret. Is there any pathology? Okay. So the volume, that will be volume displacing or flow sensing. The volume, it is going to directly measure the volume, and flow sensing, they will be directly measure the air flows and electronically integrated into volume. Okay. So either volume displacing or flow sensing. The Helios, that is your flow sensing. So once you are blowing, then there will be one turbine. So it is going to sense it. Then it is going to, that will be your mechanical energy. Then it is going to transfer into electrical signals. Okay. So this is your simple. So this is one we have in our department, but this is little different. So this one, this is a, we call it double wall cylinder. Okay. So it is a outer chamber and a inner chamber. Okay. So you can look over here. This is the outer chamber and we have a inner. The inner one is like a inverted bell. Inverted. Okay. So and it will be connected through a mouthpiece. Okay. And this is the pulley. Okay. So it will be attached to the your outer inverted bell. It will be connected. That is your pulley. Okay. So once you blow, okay, so the air is going to rise up the bell. Okay. Then it will be recorded. There will be pen will be connected. Then it will be recorded in a, that is we call kymograph. But in our department that is different. But this is the working principle is same. Okay. So that is a kymograph. It will be recording and you will be getting the graph we have shown. Remember the graph which has all the volumes and the capacities. Okay. So it will be recorded in a kymogram. So once you blow the air, so it is going to, the bell will rise up or it will go down. Okay. So that is a principle. Okay. And you will be filled this one with water. So water is going to act as a seal. Okay. So that the air does not leak out. Okay. So it will be connected. So after you blow, then the bell is going to rise up. Okay. And it is, you can see there is one counterbalance weight. So when you, the pulley will be rising up when you blow air. So even the, it will be balanced by the counterweight. So that will control the movement of the pulley. Okay. So this one we have. Okay. So this is called student spirometer or simple spirometer, or is also called vitalograph. So it has different names. So you have to know it. Okay. So this is the mouthpiece. This is corrugated rubber tubing. Okay. This is the outer cylinder. So this is the inner cylinder. So it will be inverted. Okay. And it will be by a spring. It will be connected to a pulley. So this is the dial where we have markings 500, 1000, 3000. Different markings are there. Okay. Then this is the pulley counter. This is the pulley. You can see this balanced by the pulley counterweight. Okay. Okay. So I told you we cannot measure residual volume, then functional residual capacity and total lung capacity. So for these things you have to use different methods like your helium, dilution method. Okay, so here what you're going to do, so there is two types of volumes are there. So there is a helium cylinder, there will be helium gas will be there. Okay, so there will be concentration and volume. Suppose before equilibrium, that means before the person started taking the inspiration, that is before equilibrium. Then before that the concentration is C1, the volume V1, and in the lung the volume whatever we have, we don't know that, but the volume and concentration of this we know. Okay, so this is one is known volume concentration, another is unknown volume concentration. So once the person will be starting taking the inspiration, so after the equilibrium we will be using this formula. So this is comes your application of Boyle's law. Do you know what is Boyle's law? Physics. Boyle's law. What is Boyle's law? P inversely proportional to the volume. Okay, so if you apply this formula, so that is if the temperature is constant, so one value has to be constant. Okay, so they say that the equilibrium both has same number of molecules. Okay, so why I am writing this, because before and after, so that is both will be equal, because it is just distributed here only, right? So this is the previous one, C1 V1 equal to C2 is the newer one now, after the concentration has already decreased because it has already gone into the lungs now, right? So that is a new one, C2, and the volume will be the lung volume, this one from here, and the lung volume V2. So after you put here, then they are going to find out how much is the functional residual capacity. Okay, so this is the principle of your Boyle's law. Okay, another is your body plethysmography. Okay, so here the person will be sitting in a chamber. You have seen the telephone booth chamber, jahan pe it is made of glass, na? So person will be sitting, okay, in a chamber that is made of glass, that is airtight, and will be connected through your outside source. Okay, so and this is the various pressure volume. Okay, so once the person will be taking or expanding the lungs, so there will be some pressure and volume change. So again you are going to apply the Boyle's law, and you are going to find out the functional residual capacity. So you can see, so this is the newer volume achieved, VL plus the delta V, and the pressure is going to decrease, P minus the delta P. So we are going to apply the same thing will come, CV is equal to newer one, and the after how much you will be getting. Okay, so the person will be sitting in an airtight booth. Okay, so that is pressure gauge, it is going to measure the pressure, how much is inside, and this is the outside air source. Okay, so that is this basically maintained by like electronically. Okay, so this is the setup. Okay, this is the body plethysmography. Okay, this is a airtight chamber, the person will be sitting here. Okay, then the door will be closed. Okay, then you will be breathing through a pneumotachograph from here, that is called pneumotachograph. Okay, another method is nitrogen washout method. So the subject will be connected to a system at the end exhalation, and will be breathes nitrogen free air. So at the start of the test, so lung will be containing, so there will be different concentration of the nitrogen. So here we are taking as 80%. Okay, nitrogen is evenly distributed. So after the balancing, that is your again C1 V1 equal to C2 V2. C1 is the concentration of nitrogen at the beginning. Okay, that is in the lungs. C2 is the concentration of nitrogen at end after the equilibrium. Okay, then V2 is the volume in bag, and V1 is the FRC you have to find out here. Okay, so they will be putting how much is the concentration, then they will find out the V1, that is your functional residual capacity. Okay, so this is the just the graphical representation or picture for your better understanding. Okay, so you can think this is our lung. Okay, and this is the alveolar sac, so it will be connected to a tank Okay, 100%. Okay, then they'll be breathing in and out of nitrogen. Okay, then they're going to find out how much is the change in the volume and pressure. Okay, so now I'll discuss about the diffusing capacity. So that is also another very big topic. If you are interested, you can go through. Okay, so diffusion capacity means they are going to find out how well the oxygen and carbon dioxide is diffusing into the lungs, from lung to alveoli or alveoli to the your blood. Okay, alveoli to blood or blood to alveoli. Okay, so the patient inhales very small same amount of carbon monoxide and is going to hold it for a 10 seconds, and after that he is going to exhale it. Okay, so if there is low diffusion, okay, capacity is coming, that means there is some damage in the alveolar capillary membrane like your emphysema. Okay, then pulmonary fibrosis. If the value is normal, so it can be seen in case of asthma. Okay, where the pathology is in the, where is the pathology in the asthma? In the in the bronchioles, right? So the person is having problem in the bronchioles, not in the air. Okay, so the diffusion will be normal here, but the problem is in the bronchioles, terminal bronchioles. So if that is normal, so you can suggest that is asthma, and if it's low, it can be seen in case of where the alveolar capillary is damaged, like your emphysema and your pulmonary fibrosis. Okay, then ABG, that is arterial blood gas analysis. So that is essential part of diagnosis and managing patient oxygenation status. So we'll be telling you about the acid base balance also. So that is another very big topic. Okay, so they will be collecting arterial blood from artery like your radial or femoral artery. Then they are going to estimate the partial pressure of oxygen, carbon dioxide, then H plus. pH means the H plus concentration. Okay, then they will be going to, these are the various indications. Okay, so from there they can find out the acid base balance. They are going to find out the respiratory alkalosis, acidosis, all those things. Okay. Okay, so these are the dynamic lung volumes. Okay, so we have the capacity, we have force vital capacity. So what is that? Force vital capacity. So that is the volume of air that can be expired rapidly with a maximum force following a maximum inspiration. So here we have the air has to be expired rapidly, okay, and with maximum force. That is force vital capacity. Okay, so after you take the maximum inspiration, then the air has to be breathed out rapidly, okay, with maximum force. Okay, these are the components. We have FEB1, FEB2 and FEB3. So what does FEB1 means? The force expiratory volume in 1 second. So you can see this is a normal tidal expiration. So after the person is taking the force vital capacity has already expired. Okay, so within 1 second, that is FEB1, then 2 second FEB2, 3 second FEB3. So this is the your dynamic lung volume. So here you are taking the consideration of time in second. Okay, so these are your dynamic volumes and capacities. Okay, so your FBC is important. So with this you can give a diagnosis of your restrictive or obstructive lung diseases. Okay, so the procedure same only. You have to check the calibration, then you have to explain. So one important thing is you have to explain the person. You have to give a proper instruction. Then he has to follow that. Okay. Then you have to ask history of smoking, any recent illness, any recent surgery and all those. Okay. Then measure the height and weight, because these things also going to influence the volumes. Height, weight. Okay. Then you have to demonstrate. Okay. You have to tell him to sit straight. Then the head slightly elevated. Then inhale rapidly and completely. Okay. Then the position of the mouthpiece has to hold correctly so that there is no air leakage from the mouthpiece. Okay. Then he has to exhale maximally with force. Okay. So this is another diagram. So this displays the volume of gas exhaled against time and provides. So I'll be showing you various graphs, flow volume curves. Okay, the next will be flow volume curve. Okay. So the result you can find from this graph, you can find out the FBC, you can find out, then FEV1 you can find out the ratio. This ratio is very, very important to find out the obstructive and restrictive lung diseases. Okay. Then you can find out the expiratory flow FEF 25 to 75. So this is the graph. Okay. So this is the force vital capacity. So in 1 second, so this is the time in x-axis and this is the volume in liters in y-axis. Okay. So this is the TLC means total lung capacity. So after you take air inside maximally, so beyond that your lung cannot hold it. So that is your total lung capacity. After that you are going to exhale it forcefully, rapidly. Okay. Then you are going to obtain this graph. Okay. So you can find out FEV1, that is in 1 second, right? So the computer is going to calculate the values. Okay. And this ratio, so normally the ratio should be more than 80%. Okay. And if it's less in restrictive or obstructive, what is the difference? What is obstructive lung disease and what is restrictive lung disease? So what is the basic difference? Obstruction means, so there is obstruction while taking air also, and restriction, that is some kind of restriction is there in the chest wall or in the lung itself, so he cannot take air because there is difficulty in exhaling. Okay. So this is the flow volume loop. Okay. So it is displaying flow rate during a force maneuver as a function of volume of gas. So this is the flow. So after you exhale, then you are going to inspire again. After you exhale, then you are going to inspire again. So it is going to complete the loop. After you expire, then you are going to inspire again. So the downward loop is your inspiration loop again. The down one. Okay. So that is the same thing. PEFR is your peak expiratory flow rate. So that is the greatest flow which is achieved during expiratory maneuver. So this is the highest, right? This is the peak expiratory flow rate. Okay. So here also you have different percentage, 25, then it is 50, okay, then 75, and RV is your residual volume. So beyond that you cannot expire anymore. So some air has to be remain in your lung. So that is your residual volume. So here you will stop. Beyond that you cannot expire anymore. Okay. So we tell the person you have to continue this. You have to expire for 6 seconds at least. Okay. So if he cannot, he has to stop in the middle. Okay. And if he is coughing in the middle or this one, he is not able to perform, then you have to repeat again or you have to tell him to do again. Okay. So this is your peak expiratory flow rate. Okay. So this is the highest flow which will be achieved during your maximum expiratory maneuver. Okay. This is the PEF. And it ideally be recorded by an instrument that primarily records the flow. So in flow volume loop also you can find out. Okay. Peak expiratory flow rate. Okay. So dependent on the effort and the lung volume. So these things are also again important. That is effort dependent. How much effort you give or how much you practice, you can perform better. So this is again effort dependent. Okay. So this is important. They will be telling you the strength of the expiratory muscle. Okay. Then mechanical property of lung and airways. Then inertia, resistance, sensitivity of the recording equipment. Okay. It is recommended to monitor the person who have occupational asthma. Okay. Then for detection and management of variable airflow limitation. Okay. So these are the recommendation and why it is important. So they will be telling you strength of the expiratory muscle. So you know during inspiration we need the muscles for inspiration. In expiration, do you need any muscle? Which one is active process? Inspiration is active process. Expiration is passive. Until it is not forceful, that is passive process. Okay. So that is peak flow meter. Okay. So after you blow from here, so there are various markings are there. So how much air you have flow, it is going to show in the meter. Okay. Okay. So another is maximum ventilation volume, MVV. So this is the maximum volume of air that can be ventilated on command during a given interval. So you will be telling the person, okay, to give maximal inspiration expiration for suppose 15 seconds. If you are telling more than 15 seconds, it will be very difficult for the person to do it. You will feel dizzy and there will be air washout, carbon dioxide, this one will be there, right? So only 15 seconds will be telling him to do. Okay, that will be maximal inspiration expiration at the interval of 1 second. Okay, after that the volume of air moved is either recorded by a spirometer with a writing point or collected in a Douglas bag. So it can be recorded. The Helios spirometer I have shown you, remember? So there also you can record it. Okay, Helios spirometer. Then normal adult male, it is around 82. So after you have done for 15 seconds, then you are going to calculate for 1 minute. Okay. Then adult male, that is 80 to 170. Okay. Then that is reduced in patient who has emphysema, then airway obstruction, then very poor respiratory muscle strength. So in this case, the MBV volume will be lesser. Okay. So normally that is 80 to 170. So we will be telling the person to take maximal inspiration expiration for minimum of 15 seconds. Okay. Then what is minute ventilation? So you already know your respiratory rate, tidal volume. So how much tidal volume you are taking in 1 minute? So that is your minute ventilation. Okay. So volume of air inspired or expired per minute. So it is equivalent to tidal volume into respiratory rate. So tidal volume normally is 500 ml. So if your respiratory rate is 12 to 15, you can multiply with that. Okay. Then normally it will be coming 6 to 7.5 liter. So that is your minute ventilation. So what are the dynamic volumes you know now? Force vital, FEV 1, 2, 3. Then what else? MBB, maximum ventilation volume. Then this one, minute ventilation volume. Okay. Then others are also peak expiratory flow rate, all those things. Okay. Okay. So now we'll talk about obstructive then versus restrictive. So obstruction means that is characterized diffuse airway narrowing. There is narrowing. There is obstruction in the airway. Secondary to different mechanisms. So examples are your asthma and emphysema. Then restrictive, it is characterized by abnormal reduction of lung volumes, either due to alternation in the, there is some pathology in the lung parenchyma. Okay. So, or either there will be some restriction in the outside of the chest wall. Like you can give example of scoliosis. You know what is scoliosis? There is lateral bending of the spinal cord. So in that case, the chest wall is already deformed, right? So there will be some kind of restriction. Okay. Then if there is any neuromuscular disease, respiratory muscle paralysis, okay, then your intestinal fibrosis. Okay. So these are the examples of restricted disorder. So you have to know the basic difference. So obstruction means there is narrowing of the airway, okay, like asthma, okay, then emphysema. And restrictive, there is abnormal reduction of lung volume due to there is alternation in the lung parenchyma or disease of pleura, chest wall or muscle weakness. So there is some kind of restriction either in the chest wall or in the lung itself. Okay. So these are the various examples. Okay. So you have to know this graph. So this is the obstructive disorder. The graph will be looking like this, and this is the restrictive disorder. The graph will be looking like this. Okay. So in expiration, you can see there is scoop out of the your expiration limb. So the person cannot expire. Okay. And here that is very tall. Okay. Tall and thin. Right. This one is for restrictive lung disease. Okay. So two graphs are different. This is for your obstructive lung disease. That is, the graph is the dash, you can see the dash line, that is supposed to be the normal. Okay. So if you compare to the normal one, this is very, very less. Scoop out is there. Okay. And this is tall. Okay. Tall and thin. Okay. So this is another graph. So this is a normal person for FEV1, okay, and FVC. This is a normal graph for the normal person. And if the person has obstructive disease, then you can see the FBC is going to reduce, right? So here in this case there is around 4 liter, you can say, and here it is going to reduce to half, almost around 2 liters, okay. And in restrictive also, that is only 2 liters. So if you see the FEV1, the ratio is also less, okay. So that is around 1, okay, and this is 1.8. So if you multiply those, so for restrictive, that is around 50% you are getting, that is less than 80%. But in this case, you have to remember it might be normal, okay, in restrictive disease. So only difference will be the force vital capacity will be less. The person cannot take air inside because of the restriction. Okay. So these are the gradings we have. Okay. So for mild, supposed to be the FEV1. So if your FBC is 100, suppose, so FEV1 supposed to be, you have to finish within 90% of FBC. Then your FB3 by 97%. Okay. So here it will be reduced in your obstructive diseases. These are the gradings. Okay. There will be 70 to 100, then moderate 60 to 69, then moderate severe 50 to 59, and very severe is less than 35. Okay. And you have to know the ratio. Okay. So normally it should be more than 80%, remember. Okay. So here it is going to reduce to 0.7 FBB1 divided by FBC. The ratio is important. Okay. Normally it should be 80 or 0.8. Okay. And this is the restrictive lung disease. So in moderate mild case, it will be 70% of the predicted. Then there is all statistical analysis. These are the gradings. If you are interested, you can remember. Okay. So like how you can know what type of or how much is the grade of the obstruction or restriction. With this, you can find out. Okay. Then moderate 60 to 69%. Then in mild, the FBC more than 70% of the predicted. Okay. In very severe, it will be less than 35%. Okay. So you can understand, you understood, right? What are the PFT or lung function tests? These are basically, what are those? Invasive tests, group of tests. So here you can find out the static lung volumes, dynamic lung volumes, right? You have to know what are the static lung volumes, what are the dynamic lung volumes, what are the various methods. Then we cannot measure by simple spirometer. What are the things we cannot measure? Reserve volume, then residual volume, functional residual capacity, and DLC. So what are the methods we can use? Other methods, nitrogen washout, helium dilution method, then body plethysmography. Okay. Then what are the other aspects of your pulmonary function test, like your diffusion, lung capacity, then ABG, arterial blood gas analysis. You have to know the difference between restrictive and obstructive lung disease. Why the ratio is important? FBB1 by FBC. Okay. So what are the dynamic lung volumes? FEV1 2, 3. So that is consideration of time. Then maximum minute ventilation. Then your minute volume, minute ventilation. Okay. Peak expiratory flow rate. Okay. All those. So now let's go to the this one clinical lab. I'll show you. You have to perform in the vital capacity in the student spirometer. So we have student spirometer and we have digital Helios spirometer. So today we'll be doing both. Okay. So now let's go to the clinical lab or simple spirometer. So you might get in your exam this one. Okay. So you will be tell to ask you perform vital capacity. Okay. So what are the parts? I'll tell you first. So this is the outer cylinder. So this is the inner cylinder like an inverted bell. Okay. So inside you will be putting water. You can see there is water. You need to fill the water 3/4. And the capacity of this bell is 9 liter. 9 liter. Okay. And this is the string. Okay. This is the dial. Okay. So this is the pointer. So before performing, you will have to always set the pointer in 0. Okay, and it should be flat like this. Okay, and then see this counterweight. This is the pulley. That is inside one pulley is there. Okay, this is the counterweight which is balanced. Okay, so vital capacity. So how are we going to perform? And this is the mouthpiece. This is the corrugated rubber tubing. This is the leveling screws. So this is to balance the water. So if that is tilted to one side, so while you are performing, there will be some kind of friction. Okay, and this is the water outlet. So you can drain the water, then you can fill it. Okay, so this is the mouthpiece. Okay, so acha. Okay, so first we will be performing in standing. So will be kept in 2 types of solution. So one will be antiseptic solution, one will be plain water. Okay. So before doing, you have to first sterilize it. Okay. So dip into the antiseptic solution. After that, the normal water. Then if you have your hanky, or you can use cotton to wipe it. Do you have your hanky? So hold it. So before doing, the pointer should be at 0 always. Okay, and it should be flat. And you have to check first, is there any leakage or not. So how are you going to check that? Close it. It's not going down, right? That means there is no leakage. Okay, so you have to take maximum inspiration. Then close the nose, breathe out from your mouth maximally, forcefully, as much as you can. Okay? So you have to take sitting, standing में 3 readings, sitting में 3 readings. Then you have to take out the best one. Best means which is the maximum value. करो. Breathe out. कितना है? Okay, one more thing I forgot to tell you. While you are performing, you should not see the dial. Why? Because you are trying to you will try to manipulate it. You will be knowing it. So while performing, either you see other side or look down, then perform. So these are the precautions. Okay. So एक बार अच्छे से try करो. You take maximum inspiration, then breathe out maximally, forcefully. Okay. जोर से, जितना जोर से हो सके. If you are not taking maximum, your lungs air नहीं है, you will not be able to breathe out properly. कितना? 4,000. Okay. So we are going to take 3 readings. Okay. We'll be writing in ml or liter. Okay. Then now give him one chair. Chair दे दो उसको एक. So ideally, I will just show you one demonstration. Okay. So normally, you have to exhale as much as you can, forcefully. Okay. Better. बैठ के करो. So there will be difference. You can know the difference now. 4,000, still 4,000. You take inspiration without looking at that, forcefully nikal. Okay. So I think Helios will be more than 4,000. I feel like that. It's stucking. It's stucking. रुको हाँ 4,000 से ज़्यादा नहीं जा रहा है. I think there is some problem with this.
No, it is
Okay, so this is how you do. You know the procedure, right?
Yes.
Maximum inspiration. This is, I think there is some problem with this pulley or something. Okay, it's not going beyond 4,000. Okay, so this is how you have to do in sitting and in standing. There will be definitely some values will be changed. Sitting it will be lesser compared to the standing. So that is the effect of posture on vital capacity. Okay. So now I think you go for your briefing. Okay. Then after the briefing is done, you come and practice, all of you, this one and another spirometry. That interpretation sir will teach you. Okay. So now you go for your briefing. Okay. Then come here, practice this, write down. You have to write in your practical copy. Okay. So this is the procedure how you do it. Okay. Chalo, jao.
We'll first discuss what is this device. So in theory you've learned about lung volumes and capacities, right? Static and dynamic you have learned. So you have learned about vital capacity. So what is vital capacity if I ask you?
The maximum volume is expelled out
After forceful inspiration. So maximum volume of air that you can breathe out after forceful inspiration, right? That is vital capacity. Now there is one term called as forced vital capacity. So there were two terms broadly, static and dynamic, lung volumes and capacities. So what was the basic difference? So when you say vital capacity, it is a static thing, and when you say forced vital capacity, it is a dynamic thing. So what is the basic difference between static and dynamic? Time with respect, yes. So very important there. So dynamic means there is something we are recording time also. But are you recording time or something in context of time, in respect of time? So what are you recording? So digital spirometry is measurement of volumes as well as flow rates at defined within defined breathing maneuvers. So we cannot do anything at our wish. Breathing maneuvers are defined. As per that breathing maneuver, what was the volume that has been exhaled and what was the flow rate? That means the velocity at which the volume was exhaled out, or for that matter inhaled. So there is this component of time. So now you have had an exposure of how vital capacity is recorded. So that is a simple spirometer or a vitalograph, right? So in that setup, time component you cannot measure. But in sophisticated setups like this one is a digital spirometer where we have one pressure transducer here. So this transducer is actually within this part. So this is the body of the spirometer. So this spirometer, the model is RMS Helios 401. So there are various models of digital spirometer. This is one such model. Now what are the basic parts in this? This is, as I said, this is the body. This thing that you see here, which is going inside, this is having this turbines through which the flow rates can be measured. Volume to ho hi raha hai. Volume measurement is possible even in very simple setups like you have seen there. But we need some turbines to see the rate also, right? In very simple words. So this setup is here, pressurized transducer, which has veins, rotating veins with which you can measure the flow rate also. So what we'll see here is along with the volume, the flow rate will also come. So this is the mouthpiece. So this will go inside your mouth whenever you're performing the procedure. This is a cable which is connecting it to a software. Now what are there in the software? So if you look at the interface of the software, this is what comes. Right? So first here you need to enter your anthropometric details. So vital capacity depends on a lot of factors. Weight, height, age, right? So all these things are there in the book also. These are, you have all learned about this. These are factors on which vital capacity normally depends. If the age is less, vital capacity will be less. If you compare the lung volumes of children and adults, तो children में वो वैसे ही कम है. But if I just take that value and without knowing the age, if I look at it, I would find that it's less. So that is one like context, age. So similarly, height is also important. So for every centimeter of height, the vital capacity is roughly 25 ml in males and 20 ml in females. This is your predicted vital capacity. Right? Weight also is an important factor. Ethnicity is important. How ethnicity is important? Because ethnicity decides what is the body composition. So within the our body, we have muscle, we have fat, all of this. So even within muscles, there is a ratio of white and red muscle fibers. So these things are different from different parts of the world, not only in India. So ethnic factors are also there, right? So muscle strength is a very important factor. Muscle strength is decided by all of this. Now, all of these factors you have to enter into the, whenever we are recording the spirometer, this vital capacity for a fresh subject or a fresh patient, this thing needs to be entered, right? So first we will enter, we're going to be the first subject. So first we'll give an ID. So this is we'll name TSMC. You can come this side. एक बार में we'll see. That's why we've chosen 5 subjects. So जो अभी देख रहे हो, they will make space for the remaining. So 2026. This is our ID. Your name?
Sajid. RSCH ID.
So you have to inhale with your nose first. So deep inhale as much as you can, right? Exhalation के time पे, because we are doing it, it is a dynamic thing, right? So emphasis is as much as you can exhale and as fast as you can. दोनों important है. So here we are adding one more component in the instruction. Okay, as much as you can exhale and as fast as you can. So both of these things have to be ensured. And after that, exhalation के बाद, exhalation you have done in the mouthpiece without stopping. You have to inspire with the from the device again. So पहले हमने inhalation किया with the nose, maximum inhalation, followed by exhalation into the device, and then followed by inhalation from the device again, with this time again with our mouth, right? So this is how it is going to be done. So the mouthpiece, whenever you are performing the procedure, it has to be inserted fully within the mouth or oral cavity, so and the lip should be sealed tightly so that air is not leaking. Nose also can be clipped. You have nose clips like this, but if they are not tight enough, you can use your own fingers also for clipping. So because this has to be done against your own standards. Now you follow what I am doing. Suppose I have the device in my hand. So you sit straight, right? After rest, of course. So breathing जब तक resting या stabilize नहीं होगा. Stable respiration के बाद ही this has to be done. So 4-5 minutes you have to give for this breathing pattern to be stable. Right? So then you have to take a deep inspiration with our nose. So as you can see, as I am taking this deep inspiration, I am slightly extending my neck, right? Because this makes that trachea more in line. ज़्यादा नहीं है. This is not to be hyper. Don't look upward. Slight extension, 10 to 15 degrees extension, and followed by this, you have to exhale this, right? So suppose I'm holding it in my hand. So this has to be done. So first I have taken inhalation through the nose. So I have put the mouthpiece inside my mouth, lips tightly sealed. Nose, you can use this nose clip to clip the nose, or I can use the fingers also. And then, as much as you can and with as much speed as you can, exhale into it without stopping. Again, you have to take a deep inhalation. I'm again showing. So preferably कोशिश होना चाहिए कि at least till 5-6 seconds. 6 seconds is the ideal they tell. You should be able to stretch it as much as you can. Process clear है?
The last inhalation also be taken from the
नहीं.
mouth.
Yes, mouth. Okay, so yeah. So once you have this graphic, that means the connections and all are fine. Now you're good to go. Not good. There is a lot of air leaking from the sides, right? So this graph that you see here, those are seeing. So the shaded part आपको दिख रहा है screen पे, this is where the predicted range it should lie, right? So it is grossly less, and the morphology of the curve is also not proper. So one good thing about this display is when the procedure is getting recorded. So you understand this is very user dependent. Maneuver अगर अच्छे से नहीं हुआ, then whatever comes will also not be right. So this has to be seen very precisely whether the maneuver that has been done is accurate or not, or acceptable or not. So this is not an acceptable maneuver, right? दोबारा होगा. So lips should be tightly sealed around the mouthpiece.
Okay.
पहले take a deep inspiration. So what is the reason? If you do not take as much as you can, so what will you exhale out? So that part is very important. But this time, I have not started the recording.
Oh. So as you can see, this one is better, right? Visibly better. This is the ideal morphology of the loop. And software gives its own interpretation also. But again, as the subject expert, I have the discernment to decide which one is correct. If I feel this is acceptable, I'll go with this one. If I feel that was the right one, I'll go with the other one also. So this is a software interpretation. This also looks visibly better than the last one, the second maneuver, right? So new maneuver is better than the old, so we'll accept the new maneuver. So now you have two things. So as per ATS guidelines, American Thoracic Society guidelines, 3 maneuvers are to be done, 3 acceptable maneuvers. And unme se the best one is to be taken into consideration. And in between you can give 1 to 2 minutes break, pause. So I think we have given 1 minute break while talking. Again, wait. Ruko. Go. It's not good. So old maneuver is better, so we'll still accept. So we have 3 maneuvers now. Okay.
So maneuver 2 was the best one. This is maneuver 1, which is not acceptable. Maneuver 2 was good. Morphology wise, it was the most accurate one. And this is maneuver 3. So if you compare all the 3 together, you can also have it here together. So maneuver 2, the one in the blue, as you can see, this is the best one. So for this subject, we'll record maneuver 2 as we'll save that. Maneuver 2 is saved as he's recording. Done. So after this, you can directly go to result. So you'll get the entire panel for comparison. Okay. So now we'll have one more. So we'll have few recordings more.